dizziness. And we will discuss posterior fossa anomalies, which are not very common malformation, but I think they are very important because they overlap with the normal development of the brain. So it's quite important to understand what they are to distinguish them from the normal appearance of the developing brain. First of all, methodology. How do we scan the posterior fossa? Well, in routine views, in routine scans, that I think is the only view that is really necessary, is more than adequate for patients that are at low risk. A suboccipital-pragmatic view that has been described in many publications that demonstrate the cerebellum and the cisterna magna behind it. And it is recommended, as it has been discussed before, to measure the transverse diameter of the cerebellum, mostly, as Rabbi was saying, to demonstrate, to remember to you that you have to see the cerebellum and to demonstrate that you have seen it. And then you should also see that there is some fluid posterior to the cerebellum. It is not really necessary to measure it. It is necessary to see that there is some fluid, that it is not too much. But if you want to have some quantitative threshold, there should be more than 2 millimeters and less than 10 millimeters. This is good for lower risk patients, but if you have a patient that is at a high risk for some cerebral malformation, or if you have an uncertain result of a routine scan, then you will need other views. Basically, 2 views. The second most important view is an axial plane that is obtained at a slightly inferior level, so down into the skull, that is useful to demonstrate that there is a cavity, which is the fourth ventricle, and this cavity is separated from the cisterna magna by an echogenic area of tissue, which is the inferior portion of the vermis. This is very important because, honestly, this is the only way that you can demonstrate that the cerebellar vermis is present. Because absence of the vermis can be misleading and may even create a normal appearance in the routine views. To be sure that the vermis is present, you need to check the fourth ventricle and you need to see that there is echogenic tissue between the fourth ventricle and the cisterna magna. Then this is another very important view, which is the median view that has been described before. It is more or less the same than you use for the corpus callosum. Sometimes you need to orient the position of the transducer slightly different, like from the back of the head, from the posterior fontanelle, but usually it is possible to get it, and this is useful to demonstrate the vermis, the triangular fourth ventricle, and the cisterna magna, which is inferior and posterior to the vermis. It is not always so easy to get this view. Frequently, it is not so easy to be completely certain that you are exactly in the midline plane, that you are not slightly off. And that is why I believe there is a very important role for three-dimensional ultrasound in the evaluation of the posterior fossa, because if you obtain a volume, even from an axial approach, like in this case, you can position the scanning plane exactly where you want, and you can be sure that you are exactly on the median plane. I think that these images that were obtained from scanning axially in a very easy way are sufficient to make a complete and detailed evaluation of the posterior fossa, because you can see the fourth ventricle, you can see the vermis between the fourth ventricle and the cisterna magna, you are completely sure that you are cutting in the midline, and you can see in the reconstructed median plane the entire cerebellar vermis. So three-dimensional ultrasound is useful because it facilitates to get the median plane. It is also useful because it allows you to be completely certain of the place where you are cutting, where you are placing your view. Posterior fossa anomalies, as we discussed before, are not very frequent. We grouped together our experience with another large center in Italy and put together our experiences in a publication that has been published online just in December last year. And as you can see, we have seen a little bit over 100 cases of posterior fossa malformation in a period of 10 years. Roughly is less than 1 case every month, considering 2 units. They are slightly growing, but clearly they are not so frequent. There are many different types of problems that may arise in the posterior fossa, and clearly we have no time to go over any single entity because there are just too many. The list is too big. So we will just focus on the most common one. And the most common one are by far the abnormal fluid collection. In our experience, 90% of abnormal findings in the posterior fossa arise from the presence of an abnormal fluid collection in the posterior fossa. And basically they can be divided into two main categories. Cases in which there is a rather normal looking cerebellum, but there is a lot of fluid posterior to that, let's say more than 10 millimeters, is a conservative threshold. And cases in which there is the impression that there is a cleft into the cerebellum. A cleft which is connecting the area of the fourth ventricle to the area of the cisterna magna. This can be associated with an increased size of the cisterna magna or not, and usually it is difficult to assess the depth of the cisterna magna when you have a cleft because you don't really know where to put the calipers. 90% of the abnormal findings in the posterior fossa that we have in our laboratories belong to one of these two categories. And we discuss about these two categories, but first of all, let me take you back to the normal development of the cerebellum because it is important to understand them. This is the fourth ventricle at 8 weeks that has been discussed by Bernard Benoit before. At this time in gestation, the cerebral vesicles are very, very large, and the one that will develop eventually into the fourth ventricle, the rhomboencephalon, is by far the largest, as you can see, the biggest one. Schematically, this is what happens in early gestation, around 9 weeks, let's say. The fourth ventricle is a very large cavity, a very large fluid cavity, and the cerebellum is very small and is found on top. Then, if you have an interest, below that, there is the choroid plexus of the fourth ventricle that can be seen. The cerebellum is small and is on top of the fourth ventricle, and with time, with development, the cerebellum will grow to cover completely the area of the fourth ventricle, will completely enfold the fourth ventricle inside, and the fourth ventricle will remain as a small triangular cavity right there. At the bottom of the fourth ventricle, there are the exit foramina of the ventricular space, as you certainly remember from neuroanatomy. Inside the ventricular cavities, the cerebrospinal fluid is formed by the choroid plexuses of the lateral ventricle and the fourth ventricle, and it flows continuously inside the ventricles, and it exits into the subarachnoid space at the level of the fourth ventricle, at the level of the exit foramina, which are the foramina of Luschka and Magendie. What happens is that very frequently the fourth ventricle is not completely enfolded inside the space formed in between the cerebellum and the brainstem, but there is a small protrusion that is found below the cerebellum that was originally described by an embryologist under the name of Blake. This is fundamentally a prolapse of the fourth ventricle inside the cisterna magna, and is very common. And you can see it. If you look at carefully with high-resolution ultrasound, you can virtually see it in all cases. A small circle just posterior to the cerebellum. Originally, we thought that it was just septations of the cisterna magna. But in reality, if you look at that very closely, you will see that there is even a difference in the density of the fluid. The fluid is more corpusculated in the cisterna magna, and it is much more clear inside the ventricular space, which is obvious because the Blake's pouch belongs to the ventricular cavities, so it has a smooth lining, while the cisterna magna belongs to the subarachnoid space, so it is crossed by many septations. So this is a real structure that is present in virtually all fetuses around at least 20 to 22 weeks gestation. There are many variations in this normal embryological structure, remnants, the Blake's pouch. This is normal, which I guess is present in the vast majority of individuals at around 20 weeks. but it can undergo expansion for reasons that are not completely clear in normal fetuses or in abnormal fetuses. This may result in a cystic area in the posterior fossa, which is sort of obliterating and distending the area of the cisterna magna. And this is the condition that is commonly referred to as megacisterna magna. Most likely, almost all cases of megacisterna magna that are described are the consequence of a large Blake's pouch cyst. Or you may have another different anatomic situation, and it is unclear why there is a difference in these two cases, but you find them, in which there is an enlargement of the structure, an enlargement of the complex that is formed by the Blake's pouch and the fourth ventricle. They go together. There is no anatomical distinction between the two cavities that will cause a superior rotation of the cerebellum. That is how the neuroradiologists call this, a rotation. The cerebellum is just displaced upward. You have to remember that the cerebellum is hanging down from the cerebellar peduncles and just leaning against the brainstem. So if there is a cystic structure below that, it will elevate the cerebellum and will cause a rotation. This is by far the most common entity to be identified. It is the megacisterna magna, and radiologists have always defined that as a large cisterna magna. Obstetricians like to do measurement, and they have defined that as a cisterna magna that is greater than 10 millimeters. This is a rather conservative approach, because by doing that, probably a little bit less than 1 in 100 fetuses will have a megacisterna magna, so it's not so rare. The definition is that you have a cisterna magna that has a depth of 10 millimeters or more with a normal cerebellum. This is magnetic resonance in the third trimester of gestation, and this is the same infant after birth. And as you can see, very typically, very commonly, there is an evolution. Most of the cases that we see in utero will undergo regression, and the cisterna magna will remain large, but will be significantly less than we have seen in utero. It's a very, very common evolution. So a normal cerebellum with more fluid posterior to that. And if you scan with a very high resolution, you can see that? The contours of the Blake's pouch that has become large. Typically, there are no septation in these cases because the Blake's pouch has become large and has obliterated the cisterna magna. This is megacisterna magna. Then you have the other situation that we have described before, the impression that there is a cleft into the cerebellum. And for a long period of time, obstetricians that are, I think we are simple people, I say that in appreciation, we always believed that if there is the impression of a communication, there must be a defect in the vermis. It's not true. In many cases, there is no problem with the vermis. It's just a geometric problem caused by the rotation. If you have some fluid in between the brainstem and the cerebellar vermis, like in this case, because of a large Blake's pouch, you do not see the contours of the Blake's pouch, but it is there. And if you scan along this line, in the place where there is some fluid, then you will get the impression that there is a cleft. It's not really a cleft. It's just a superior rotation of the cerebellum. That is the basic phenomenon behind this appearance that we refer to as the open fourth ventricle. In reality, the fourth ventricle is not open. There is a Blake's pouch posterior to that. It's not communicating with the cisterna magna. It's simply prolapsed and big into the cisterna magna. Now, this is normal in early gestation because we discussed that before. In the very beginning, fourth ventricle is large and the cerebellum is small. So at 11 weeks, you will always see an open fourth ventricle. Even at 17 weeks, sometimes you may see it. Not frequently, but sometimes you may see it. So that is quite normal. It is only after 20 weeks that consistently there is no more fluid in between the brainstem and the cerebellum, and the fourth ventricle appear closed. So the traditional view is that fourth ventricle is normally open prior to 20 weeks. And prior to 20 weeks, you should not consider these suspicious. you should only rescan the patient later than 20 weeks. We will see later that probably there is a way to discriminate between normal and abnormal even before 20 weeks. But the general rule up to now has always been prior to 20 weeks, an open fourth ventricle is practically the rule. What about an open fourth ventricle after 20 weeks? That is rare. It is much less than 1% of all fetuses. And usually the three possible conditions that can be encountered with this finding are, number one, a condition which is called Blake's pouch cyst. Number two, the very common Dandy-Walker malformation, probably the condition that is best known. And number three, Vermean hypoplasia. Vermean hypoplasia is now the term that is commonly used to indicate the entity that was referred to before as a Dandy-Walker variant. There is not a complete consensus on the categorization of the posterior fossa abnormalities, but most of the neuroradiologists now believe that there is Dandy-Walker malformation, Vermean hypoplasia, and Blake's pouch cyst. The Dandy-Walker variant has disappeared. What is the Blake's pouch cyst? Which is an entity that you should become familiar with because by far it is the most common entity with an open fourth ventricle. It is a condition where there is an intact cerebellum that is mildly rotated upward. And for the neuroradiologist, it is very important to be sure that there is no expansion of the posterior fossa, which they do by observing that the sinus confluence, the tortural aerophily, is in a normal position. We'll discuss that in a moment. Basically, a completely normal posterior fossa, not expanded, with a slight rotation of the cerebellum. It gives you the impression that there is a communication between the fourth ventricle and the cavity of the cisterna magna. This is the Blake's pouch cyst. On the contrary, this is the Dandy-Walker malformation, which is probably the most famous of all the posterior fossa malformation, but by far not the most frequent. What is the most important clue to the diagnosis of the Dandy-Walker malformation? According to neuroradiologists, two conditions. Number one, the rotation, the superior rotation of the cerebellum, which is, as you can see, much more significant than it occurs with the Blake's pouch, and also a superior expansion of the posterior fossa, which is indicated by a superiorly displaced tortural aerophily. How do they evaluate the position of the tortular? Well, with magnetic resonance, it is quite easy because you can see very well the sinus confluence. It is that little triangular space. And the neuroradiologists look at that and look at the insertion of the neck muscle. You can feel where the neck muscle insert on the back of your skull, don't you? Right here. That is where the tortular is, and that is what the neuroradiologists watch after birth. This is a Blake's pouch cyst with the tortular aerophily at the level of the neck muscle. And this is a Dandy-Walker malformation. As you can see, the tortular is much displaced. You can see that the posterior fossa is much bigger with the Dandy-Walker malformation. It has become square. Is that clear? Dandy-Walker malformation is a very big posterior fossa with a very rotated cerebellum. This is probably magnetic resonance is the best way to assess the position of the tortular, even in utero, as an important contribution of magnetic resonance, because usually if you are properly oriented, you can see it very well. With ultrasound, is much more difficult because you get a lot of shadowing from the occipital bone, so you don't really see the tortular. You can infer it a little bit from the direction of the tentorium, but it's not so easy. And that is why we became interested in the rotation of the cerebellum, because an important difference between the Blake's pouch and the Dandy-Walker malformation is the degree of the rotation, and we have measured this angle in normal fetuses and fetuses with anomalies, and we have seen that there is a considerable difference between Blake's pouch cyst and Dandy-Walker malformation. As you can see, it's not a very large number of cases, but we had more cases since we published this. As you can see, in normal fetuses, there is some degree of rotation in the range of 10%, is normal. With the Blake-Sporch cyst, their rotation is always very, very mild, less than 30 degrees. And all cases of Dandy-Walker malformation that we have seen had the rotation greater than 45 degrees. So I think that this is a very important clue. Thus far, we have never seen a case of Dandy-Walker malformation with a rotation of less than 35. We have never seen one case of Blake-Sporch cyst with a rotation of less than 30. It's not 1,000 cases, we need more, but I think that this, from the point of view of ultrasound, is one of the most important findings. Also because these can be demonstrated in even very early in gestation. This is a case that came to our attention at 20 weeks. And honestly, we did not know, because the cerebellum was looking quite normal. We were sure that the vermis had a normal appearance, and the rotation was, not so bad. So honestly, we were not sure whether this was a Blake-Sporch, a big Blake-Sporch, or a Dandy-Walker malformation. And eventually, as you can see, the infant, that is magnetic resonance at birth, developed a true Dandy-Walker malformation. And as you can see, there was a progression from 20 weeks on. The cisterna magna increased in size, the situation became much more clear. But since the beginning, since 20 weeks, the angle was 45 degrees. And consistently in our experience, this is typically a Dandy-Walker malformation. We discussed it before. If you have an open fourth ventricle prior to 20 weeks, you cannot really tell if it is a true malformation or not in the majority of cases. But we have now a number of cases that we have seen between 15 and 20 weeks, and the angle, if it was a Dandy-Walker malformation, was always 45 degrees or more. This was 17 weeks, as you can see, and we were not sure at that time, and that is the image of the fetus when it was delivered. So I think that even very early in gestation, if you see significant rotation, that is worrisome. It's very likely to be a true malformation. What about vermian hypoplasia? Well, that is probably the most difficult of the situation. Vermian hypoplasia is an incomplete vermis, and some people make a difference between partial agenesis and hypoplasia, but I think that antenatally is very difficult. And what happens is that these are the two cerebellar hemispheres, this is the vermis, and very simply the vermis does not cover completely the fourth ventricle. So you have the impression that there is some superior rotation of the cerebellar vermis. It is very difficult to see this condition because the vermis is a very small structure, and it is hard to tell at 20-week gestation whether the vermis is intact or not. We usually look for morphology and we look for size. Morphologically, it is important to note that in the normal posterior fossa, there is a triangular-shaped fourth ventricle with the apex pointing posteriorly. Neuroradiology refers to this as the fastigium, so it is important to see that there is a fastigium. Number two, usually it is possible to see at least the primary fissure of the cerebellum at 20 weeks. There are two main fissures into the cerebellum, the primary and the secondary. I think it's very hard to see the secondary fissure at 20 weeks, but the primary fissure usually can see it as a small indentation right there. And the primary fissure divides the superior lobe from the two inferior lobes. There are three lobes in the cerebellum, more or less of the same size. And the general rule is 1/3 of the cerebellum is above the primary fissure, 2/3 is below. Difficult, isn't it? Yes, it's quite difficult. But that is morphologically, that is the best clue that you have to recognizing an intact cerebellum. So that is why biometry is very important. And there are several papers on biometry. This is one published by Achiron. Probably the superior inferior diameter is the most important one because usually you are missing portion of the cerebellum, so it is the superior inferior diameter which is affected. And usually at 20 weeks, the superior inferior diameter should be more than 10 millimeters. Honestly, I think we can do better biometrically than this because this is there are two studies available. They are a bit rough biometrically. They go to steps. I think that we need to develop this a little bit better. So we try to combine morphology and biometry to make a diagnosis. and it is not always easy. This, you will agree with me, is a Blake's pouch cyst with a normal-looking cerebellar vermis, good size. You can see the fastigium, you can see the primary fissure, measurement is okay, and that is a very tiny and rudimentary echogenic vermis, and that is clearly vermian hypoplasia. But what about this case? It's normal hypoplastic. Sometimes it can be very hard to tell. What about the angle? Is the angle useful? Well, I don't know, because we do not have many cases, but clearly there seems to be some progression. In our preliminary experience, the vermian hypoplasia lies somehow in the middle, in between the Blake's pouch and the Dandy-Walker malformation, between 30 and 45 degrees. It's a very small number of cases, so I'm not sure that this works, honestly. I continue to believe that if the rotation is less than 30 degrees, the chances are that it is a normal condition, a Blake's pouch cyst. If it is more than 30, it is more likely a pathological condition. 3D images are very similar to 2D images, so you can reproduce the same findings on 3D if the volume are good, as you can see. Normal megacisterna magna with a normal cerebellum, Blake's pouch cyst, vermian hypoplasia, and then the Walker malformation. So 3D is useful from the point of view of diagnosis, and I have no doubt with regard to that. How accurate we are? Well, we will never be 100% accurate, because there are difficulties even postnatally, and these are conditions that can evolve. But this is the better that we can do. As you can see, considering our experience, ultrasound was accurate in 85% of the cases. There were some difficulties in defining the vermian hypoplasia. That was the major issue that we had. 85% of the cases, you are right. Sometimes it is clear-cut, and sometimes it is a bit in a gray area. That is the best that you can do. And magnetic resonance certainly can help, but they tend to have the same problem that you have with ultrasound, of course. These are rare conditions, and it is difficult to make a differentiation, so you need to use all the instrumentation that you have, and certainly magnetic resonance can be helpful. It will not solve all the problem. Ultrasound and magnetic resonance performs more or less the same. What is the outcome? Well, this is a bit complicated slide, but I think it is important for you because it makes one point. First of all, with any of these conditions, it is very frequent to have other anomalies, malformations, and chromosomal aberration. We and even others had the experience of cases of trisomy 21 with the Blake's pouch cyst. So we believe that any time that you see one of these fluid collection, you should consider the issue of karyotyping with the couple. You should discuss it. The frequency of associated malformation is very high, as you can see, with any type. Blake's pouch, megacisterna magna, Dandy-Walker malformation is particularly high with Dandy-Walker and vermian hypoplasia, of course, but even with the others is very high. I don't know if it is the selection of cases, because all these cases were referred, but I have the impression that there is something in there. These conditions are risk factor for other abnormalities. But once you have excluded the other anomalies with ultrasound at the best that you can, it is important to note that a good proportion of cases of Blake's pouch cyst and megacisterna magna will undergo regression. They will disappear in utero. They will just go away. So that, lends credit to the idea that in some cases it is only delayed development, a big fourth ventricle that has not decreased with the usual time schedule. But they never go away, the finding, if you have Dandy-Walker malformation or a diagnosis of vermian hypoplasia. If you have ruled out other malformation, the follow-up is very good for Blake's pouch cyst and megacisterna magna. More than 90% of these infants will be completely normal at follow-up, and that, again, lends credit to the hypothesis that these conditions are risk factor for associated anomalies, but when there are no associated anomalies, there are probably normal variants, just differences in development, but normal brains. You may have normal development even with Dandy-Walker malformation and vermian hypoplasia, but this is not the most frequent outcome. in our experience, the vast majority of cases that were diagnosed in utero had other problems. Usually they had associated condition that sometimes we were not able to figure out because some genetic condition you cannot diagnose in utero. But then the Walker malformation and verminal hypoplasia, if you do a diagnosis in utero, have a very guarded prognosis. Very frequent they do very poorly. And that is why it is very important to distinguish them from megacysteroneumania and Blake's pouch cyst, because usually these are completely normal children. They have no problem at all. So, to summarize, posterior fossa fluid collection are the most frequent posterior fossa anomalies. They are not the only ones, but they are the most frequent. You have to remember that the fourth ventricle is frequently open prior to 20 weeks, but I think that in the future we will be able to tell malformation even before 20 weeks. I think that there are clues to recognize these severe anomalies even before. It is very important to obtain in each of these cases a median view to assess the vermis morphologically and biometrically, to assess the position of the torcular, and I think that from a sonologist's perspective, the angle between the brainstem and the cerebellum is very important because the normal variation, the Blake's pouch, are usually associated with very small angle. No matter what is the diagnosis, the cerebral diagnosis, it is important to rule out other anomalies, and these at present should also include discussion of karyotyping. You may discuss with the couple, also depending upon the result of the combined screening, but certainly this seems to be a very important risk factor. You have to remember that there is overlap between abnormals and normals. Blake's pouch cyst and megacysteroneumania usually when they are isolated, they are normal variant. And it is important because if you combine these two findings, they represent 50% of our entire series. So in half of our abnormal series, the case was either a Blake's pouch cyst or a megacysteroneumania, which probably, as we discussed before, are normal variants, normal children. Thank you very much.